Your metabolic health or lack thereof could be putting you at risk of vascular and cardiovascular issues. Hello, I'm Kim McNicholas, and welcome to an amazing edition of NextGen MD with Dr. Lily Johnston. Dr. Lily Johnston just came back from a conference focusing on metabolic health. It's what we talk about every single week right here on our channel, youtube.com/, the at sign, the way to my heart. Make sure you subscribe to it for more great content like this, but also Dr. Lily Johnston's channel at youtube.com/, the at sign Lily Johnston MD. Dr. Johnston, before we get into the conference, just give us the Cliff Notes version of metabolic health. Why does it, or lack thereof, why does it put you at risk for cardiovascular and vascular issues?
It's a good question, Kim. And I think what we know is that the formation of plaque in the arteries is a complex process. If it were just about cholesterol, we would have solved heart disease and P.A.D. decades ago, right? So it's about more than that. And what is the role of smoking? What is the role of type 2 diabetes and high blood sugar and high blood insulin levels? What does all this have to do with the formation of plaque? Well, that is really where the science and discovery in metabolic health comes into play as we begin to understand more about the role of inflammation and the role
Yeah.
of glucose and blood sugar control and hyperinsulinemia, the role of hormones. All of these things come into play with our vascular and heart health. And so I have personally dedicated, my career to understanding this and trying to help people prevent plaque or stabilize plaque if they already have it so that we can eliminate the need for surgery and stents in the long run.
I know you talked about estrogen, and I'm really curious, what was the focus of your talk and how does that play into cardiovascular and vascular health as well as your overall metabolic health?
So my talk was called Estrogen in the Heart, a Love Story. And it was a review of how estrogen works in the body, where the receptors are, the fact that it is actually both a male and female hormone, and it's important for men as well as women, and that we have a lot of good evidence that the lack of estrogen can be harmful. So the menopause transition is a great natural experiment for this. We see that the incidence of heart disease and cardiac events goes up dramatically after menopause for women if they are not on hormone replacement therapy. The institution of hormone replacement or menopausal hormone therapy can actually reduce that risk if it is started when patients are early in that transition period. If we start it later in life, it is much less effective, and some studies have shown harm. We could talk about that. But in general, I believe that when it is started early in the menopausal transition, so women in their 50s or within 10 years of starting menopause, it is actually a good thing for the blood vessels, a good thing for the heart, and may actually have some impact on all-cause mortality.
It was, what, in the early 2000s, late 90s, early 2000s, they put that black box warning on and saying, hey, this could actually, estrogen or these hormone replacement therapies could actually increase your risk of cancer, was it? And
The
so
Women's Health
they said,
Initiative was stopped in 2002, and Jack Rousseau, the cardiologist on the Women's Health Initiative study group, stood up in front of journalists everywhere and said that menopausal hormone therapy causes heart attacks, strokes, blood clots, and cancer. And for a generation or two, women just stopped taking hormones, doctors stopped prescribing it, and there was a lot of fear around this therapy.
are there any caveats, with the hormone replacement therapy and, putting this back out there and getting all women on it who are, in that 10-year time frame around menopause?
Yeah, I mean, there are huge caveats. The caveats for Women's Health Initiative are that women in that study were not symptomatic by design. They wanted to randomize people and blind them. So if you were treating somebody who has a lot of hot flashes and night sweats and you give them a pill and that suddenly goes away, they're pretty sure they got the active ingredient rather than placebo. So you can't blind people that are symptomatic. So they chose non-symptomatic women, which is a small subset of, I would say, women going through menopause. And they also intentionally picked women who were older. The average age in that trial was 63 years old because they wanted an increased rate of heart attacks and strokes so that they could test the question, should all women be on hormone therapy to prevent heart attack and stroke? They were hoping that it was going to work, in a similar fashion to like a lipid lowering drug or like aspirin, and we were just going to give this medicine and magically things were going to get better. So they intentionally picked an older asymptomatic population. That's the first big caveat. Second big caveat is, at that time, what was available to women for hormone replacement was conjugated equine estrogen, which is Premarin, and that is about 17 different types of estrogens, a few of which are native to humans, but many of which are not, and they behave differently. The best we had for progestins at the time, well, we did not have the ability to micronize progesterone, so we were using synthetic progestins. The one used in Women's Health Initiative was called medroxyprogesterone acetate, and it has a couple of properties that are not optimal either. It is prothrombotic. It does result in increased risk of blood clots and potentially also arterial issues like heart attacks and strokes and plaque rupture events. So that is not really what we are using today for most women for menopausal hormone therapy. Most of us are now using oral estradiol or, transdermal estradiol, either one, and we are using micronized progesterone. So both of those are the hormones that we have the most of in our own bodies. They are not, they're synthetic, right? They're manufactured in a lab, but they are the same molecule, right, that you and I are making in our ovaries. So those are some huge caveats. And I think that is really important. And when we look at the safety of estradiol and micronized progesterone, it's a pretty different picture.
Yeah. It's interesting as you were going along and you were talking about all the different aspects of the study and the criteria and how they executed it. I kept thinking, okay, well, there's a flaw. I'll ask her about. There's a flaw. Can I just say there seemed to be a lot of flaws in what they did, which is why it was
It was
overturned.
designed to answer a very specific question, and it was really designed by methodologists, right? People who wanted to
Yeah.
ask the question, but it was not really designed to assess whether menopausal hormone therapy was safe for women who were symptomatic.
And
That's a
so
different
it was
question.
really overreaching in its results and how it was implemented, right? Or
Yeah.
you know,
A-
put out
And the
there.
truth
I
is,
mean, that
if you go
seems to
back
be
and reanalyze the data,
extreme.
there were not an increase in heart attacks. That was not even true.
Oh my God.
In point of fact, women were actually protected from breast cancer had they ever previously been on hormone therapy, and there was really no increase in signal for people that were on it. So that was also kind of a non-starter. The stroke risk does seem to be real in WHI, but we've had multiple other randomized controlled trials of menopausal hormone therapy, and none of the other trials that have been done have ever found an increase in stroke risk in menopausal hormone therapy. So there are a lot of nuances to the interpretation of those results and, how I think they should inform or not the prescription of such therapies today, especially for women who are desperately symptomatic.
It was interesting because I was reading a study recently from Dr. Anita Dua from Mass General, and she had talked about clopidogrel, Plavix, antiplatelet. A lot of people use, and she was saying that in her pilot study that the clopidogrel was less effective in women than in men. And I asked her, "Do you think that estrogen levels and menopause might have an impact?" And she said that's something that they're going to look into going forward. And that could be really, really interesting and impact a lot of women.
For sure.
Is there anything else from the conference that is worth chatting about? Anything that I'm sure that a lot of patients that are looking at this, right now going, okay, so what is really my takeaway from your presentation? What are some of the questions that I should be asking my doctor? And which doctor? Should I be talking to a hormone replacement specialist? Should I be talking to a cardiologist? Should I be talking to my OBGYN or my primary care? What do you think?
Hormone therapy is still, I would say, difficult to find the right person sometimes. Sometimes we, find that endocrinologists do it. There are some OBGYNs who do an amazing job, some urologists who do a really good job, and others who don't really want that as a big part of their practice. Same with primary care folks. Some people are very interested and excited to help this population, others not so much. The other thing we didn't talk about was the men, right? I said that this was actually important for men too. And I think the most common condition that this applies to is prostate cancer and androgen deprivation therapy. So prostate cancer, much like breast cancer, is hormone sensitive, and men will have their hormone testosterone suppressed in one of several ways. And typically, because estrogen comes from testosterone, the aromatization of testosterone, if you suppress a man's testosterone completely, unless you're doing it with high dose estrogen, men will then become estrogen deficient. And I described it in the talk as menopause with a mustache, because men get hot flashes and they get night sweats. They get bone loss and osteoporosis, and they get increase in body fat. And there are a lot of similar changes that happen, just like the menopausal transition in women. But it is possible to replace the estrogen in men without having a negative impact on their cancer outcomes. And you can actually improve their quality of life. You can improve their hot flashes. You can improve their bone mineral density. And we actually have a study that shows improved quality of life on estrogen replacement for men. So I would say, especially if you have risk for cardiovascular disease, because androgen deprivation therapy has been shown to result in worsening cardiovascular outcomes, then I would talk to your urologist or your oncologist about whether it might make sense to do estrogen replacement under those conditions, and think about whether that's an option.
But that's not discussed as much for men. Who would discuss this with a man? Who would assess that in a man? This seems like something that a man has to actually advocate for himself with the primary care, to maybe go see an endocrinologist, or
It
who
would
do they
probably be
talk
his
to?
oncologist, right? The cancer doctor treating the prostate cancer, or the urologist, depending on who's really,
So it's once
quarterbacking
they
that.
have the cancer. Okay.
Yeah.
Gotcha. Do they normally, I don't have any experience with that. Do they normally have the conversation about that? Do they normally test?
That's a great question. I don't have a lot of experience in that patient population. I know that it's part of the American Urologic Association's sort of guidelines for androgen deprivation therapy, is to at least think about the implications of lower estradiol levels in men. But whether it's, part of the routine conversation to talk about replacing estrogen or not, I'm not certain.
Okay. Awesome. Well, thank you so much, Dr. Lily Johnston. Any final thoughts here? Critical questions that I know I'd asked before we got in the men, before I forget about men. Um, I we should, sorry to our producer, Josh. Um, but with women, the questions that they should ask their doctor, who they should see.
I think you should go find somebody who is certified in hormone therapy, right? You can look at the National Association for Menopause. We'll have a list of certified providers. There are some other organizations who run training. WorldLink is the one that I am also aware of. The goal is to find somebody who is comfortable discussing hormone replacement risks and benefits and alternatives, and help you as a patient come to a decision that makes sense for you. Especially if you have P.A.D. or coronary artery disease, there are going to be some concerns about adding hormone therapy, and you want somebody who is very comfortable talking through those options with you, because especially if you're having symptoms, there may be other ways to help manage those that are not hormone related, or that are just local therapy, right? And won't have any systemic impact, or a systemic way that is the lowest risk option, right? So all of those are good choices, but you're going to need somebody who does a decent amount of hormone replacement to help walk you through all that. And finding somebody who is certified is probably the best way to go about it.
Last week, we had our nurse practitioner, Deidre, who's on, and she really specializes in this as a nurse practitioner in women's health. And one of the other nurses in her practice is getting her doctorate in nursing, and she's focusing on creating a screening tool for menopausal women, because she thinks it's really important to start them on the hormone replacement therapy earlier rather than later. And as she was talking, she mentioned that PVC is being a symptom for women. And this light bulb went on for me, because we had a patient who called our Lifesaver hotline a few weeks ago. And she had a doctor. She's young, in her 40s, and she had a vascular doctor who wanted to perform a leg procedure, when she originally went in there with the complaint of PVCs, so a heart issue. And he said, "Oh, well, while you're here, we might as well check your legs. And oh, by the way, well, this is a doctor notorious for doing unnecessary procedures." And so I got her to a different doctor who is an interventional cardiologist because I wasn't as worried about her legs because she had no symptoms, but I was worried about her heart. And he was like, "Well, we could watch it and this and that, but there doesn't seem to be anything in your chart that really, or in your testing that seems to lead us to believe you have anything, great going on, coronary artery blockages, valvular issues, AFib, or anything like that." And after watching this, I was, listening to our nurse practitioner last week. I was like, "Oh my gosh, she might have a hormone issue." So I called her and she said, "Actually, someone told me a long time ago that I had issues with my hormones. I don't remember the conversation, but that is something I'm going to get checked." So definitely for women. I mean, I was surprised that the cardiologist wasn't aware of something like this, but did they talk about PVCs or anything else at the
We actually did have
conference?
an electrophysiologist who gave a talk right before mine, and we didn't talk specifically about the issues related to hormone therapy and PVCs. The general consensus certainly is that the electrical system in the heart is kind of like the nervous system in the body, and just like you can have a neuropathy related to blood sugar dysregulation, you could have an electrical disturbance in the heart related to electrical or to metabolic dysregulation. And I am not aware specifically of the link to PVCs. However, I will say there are probably over 100 symptoms that are possible in perimenopause and menopause.
Yeah.
And I'm not surprised to learn that PVCs are among them. The good news is that PVCs are typically not dangerous, and there's not a huge amount of risk associated with them, but they're certainly annoying. And if it does reflect a change in hormone levels, potentially perimenopause, then at least knowing that might give that patient a great deal of peace of mind.
Thank you so much, Dr. Lily Johnston. We really appreciate you. We need you to have a telemedicine practice in other states. We need you to get licenses in other states. Right now, she's licensed in
Working on it.
California. See, that would be amazing because we need more like you that are focusing on metabolic health and to answer more questions because so many of our patients, they really want to understand what is the underlying factors, what's driving my cardiovascular and vascular disease. And there's always something underlying related to metabolic health. And that is a really big focus for Dr. Lily Johnston. And it's so nice to see you're so young and you have so many more years ahead of you to help so many more patients. So thank you so much. If you want to follow Dr. Lily Johnston, she has great content on her YouTube channel. She puts it up very, very often with the help of our amazing producer, Josh, that we share. YouTube.com/the @ Lily Johnston MD. You can also follow our channel, subscribe to our channel at youtube.com/the @ the way to my heart. Have a great week, everyone.